we'll invite Dr. Deepthi to present her case of Topoguided PRK for case of irregular astigmatism related to SCA.
Thank you so much for having me here, Dr. Rishi, and truly enjoying the saga of cases in corneal scars. So I think, as you rightly pointed out, there's a very thin line and not a very thick line where you start looking at scars in a therapeutic treatment like PTK and go towards a refractive treatment like Topoguided. I think that junction of where you stop looking at it as a therapeutic and start looking at it at a level of being glass free or reducing the power is the key of success. So shifting from PTK to when we start looking at a refractive solution for the patient, I would just present this case. So this was a boy who presented to us a few years back. We had performed a DALC a few years back and he was off treatment. And now he had a mild nebulomacular gray scar and he came to us with an uncorrected vision of 660 with a spectacle corrected 6/9 parts. And his wish now was to be less dependent on glasses. He never liked it, he never wore them. And he also had this squint, which cosmetically he wanted to be better. So let's see how we do step by step. So when you're looking at a PTK to start looking at a refractive, one of the key component is what is his BCVA. You can do an accurate refractive surgery on scars only if your BCVA is good. There's no guideline, but I think clinically a 612, 615 is a good start to start looking at a refractive procedure. So the number one test, however smooth or irregular your cornea is what the patient perceives. Yes, there will be some debulking of the scar. The vision does improve, but you should have a baseline to start looking at refractive rather than a therapeutic PTK. So this was an ideal patient because his refraction did give him a good vision of 6/9 parts. And very important is also the health of your cornea, especially because this was a post-grafted eye, even before you start looking at a refractive solution for him. So the plan for him was to do an excimer laser followed by a squint surgery. So this was his pentacam and just a lower layer of the refraction again. Now I'll just take you through the thought process which we had and the challenges that we had to face when we were planning his surgery. So the first thing was, should I plan a surface or a flap? The thickness was quite good. So OCT is the only tool where you can decide on all this in scarred corneas. So if you look at the OCT, there is a lot of irregular epithelium. This is expected when there's a scar or an irregular cornea. And you also see a lot of scarring at the deeper part of the epithelium and also at the Bowman's and a little bit of stromal area as well. So what does this tell me? There is an irregular scar and irregular epithelium. Now, if this was a patient who had irregularity but was a clear cornea, I would probably start looking at a flap because that would give me a nice plane to start my refractive procedure. But obviously in this patient, our intention was to debulk the scar, so it had to be a surface ablation, no doubt on that. Now, how do we remove the epithelium? Now we have a lot of options. We do generally an alcohol in a regular surface ablation, or we also have an option of transepithelial where we use an excimer laser. So in this patient, it was very irregular. So how do you decide is basically look at your visual center, maybe the 3 or 4 millimeters. So the lower OCT is of his center. So it was somewhere between 70 to 90. So we decided to go ahead with an 80 micron ablation. So how do we do it? Alcohol certainly is not a good option when you have scarring at the Bowman's because your base itself is going to be very irregular. So it has to be an epithelial, a streamlight, or any transepithelial platform that you use. So we decided to do a epithelial removal only with an excimer laser, and we decided to remove around 80 microns for him. Now, when you look at what type of ablation, these are the typical cases where you would certainly want to go for a Topoguided. So if you expand his center 3 millimeters, you do see there is a significant irregularity, and these can beautifully be dealt with any sort of Topoguided, Placido, or a Schleimpfler guided ablation. So another interesting thing in this patient before we started planning is if you look at his pentacam, you see that his pupil is up. This is not a fixation error. His pupil is slightly up. That means he has a very significant angle kappa. So he's actually seeing the world, if this is the left eye, seeing the world through the inferior temporal part of the pupil. Now, this is extremely important when you plan examination laser. If you look at the overlay of the pentacam, it almost shows a 1 millimeter deviation inferiorly. Now, as we know, another simple way is just go to your pentacam, and you can also always see the fixation in the upper left corner, and it shows the patient's fixation is quite significantly inferior temporal side of the pupil, which has a significant angle kappa. Now, this is easily corrected with most of your topo-guided, because a contour or any such platforms automatically go and treat your visual axis. But if you're not using a topo-guided, it's very important that you decenter. For a simple reason is, this is again the Placido showing a significant angle kappa. And if you're not decentering it, a regular laser would put it around the pupil or center of the pupil like this, but actually you require a treatment somewhere here. So you can visualize this. This was a patient under the microscope where you ask him to look at the fixation light. It is quite inferior. If you can see my cursor there, compared to your pupillary center. So for us, it was not an issue because it was contura, but this is something you have to look for. So if we go ahead with the pupil centering, it's almost a 1 millimeter decentered ablation, and the aberrations which you're planning to treat certainly would not be. So on the day of surgery, again, it's not very easy to get a good scan, especially if you're doing a vario or a placido base like this. You have to repeatedly uh, put lubricating drops, try to get good scans, and you will manage to get a few good scans in such sort of corneas. Now, the plan was to do a PTK of 80 microns. So when I started planning, I required an optic zone of at least 8.5 because the contour was that big. So when I started planning and put an 80 micron ablation thickness, the only option the machine gave me was an optic zone maximum of 5 millimeter. So PTKs do have a restriction of how much ablation can happen. So what would we do? So we thought we'll do a two-step PTK. I could not compromise on the thickness, nor I could compromise on the optic zone. So I planned a first step PTK of 50 microns. There I could get a 6.5 optic zone, and a second PTK I planned for the residual 30 microns with a similar optic zone. Now again, because we are doing a huge decentration in contura, I also wanted the epithelial removal to parallel it. So we had to, because epithelial removal does not have a visual or pupillary centric treatment. You have to manually decenter it. So looking at my contura decentered, I went ahead and decentered the PTK as well to the inferior temporal part of the cornea. So that was done, and I decentered it by I think around 400, 450 microns. So this was the PTK planning. And refraction is extremely important because the machine eventually treats what you do. So it's very important you do multiple refractions. This was my wavefront refraction, cycloplegic, and always do check it yourself. A simple duochrome and a JCC will ensure that your optometrist has not erred. So this was the plan for the day. So first step was a 50 micron decentered PTK. Second step was that additional 30 micron decentered PTK followed by the contour ablation. So you just have to plan all this in advance so that you don't want your stromal to dehydrate, which can cause overcorrection. So make sure your optometrist has planned all this. Sorry for that. Yeah. So this is the 50 micron of PTK, and you can see, so obviously it is decentered. That's how you want it. So once you're done, you immediately put in the second PTK. And this would, you would see the contura decentration is quite significant. Almost a 0.5 millimeter is where the visual axis. So this is the excimer laser which is happening. So very straightforward, absolutely a no-touch technique, and that is the end of surgery. Very important to give a good dose of mitomycin. So our protocol is around the second mitomycin for every micron of ablation. But in scar corneas, we do sometimes slightly overexposed to mitomycin. So what happens, this was the pre-op photo, topography, and the OCT, and this was at 1 month. Cornea certainly much clearer. You just want to clear the central 3 to 5 mm, and that's achieved. Topography is much smoother. So if I look at the central 3 to 4 millimeter, it's a pretty impressive smoothing. And OCT again gives us a great clearance of the scar. Almost the entire scar in the center could be treated because your excimer laser for the contour again is debulking the scar at that level. And this is what you actually want to see. The patient went from unaided 660 to an unaided of 69 parts. So a very happy patient and certainly a happy me. So the only question the patient had is you took so many days to plan, but the surgery hardly took few minutes. And I think that is the main mantra when you are doing refractive surgery on irregular corneas like this. Your treatment has to be meticulous. You'll have to look at smaller details to really give that sort of visually satisfying results. So I think today, as we have heavily discussed till now, scars, there are so many beautiful options. And I think these are patients where you can really use the excimer or any technology to the topmost. These are irregular corneas truly benefit from the newer technologies we have. And these are the cases you have to spend a little more planning the surgery. The surgery itself is super easy, but I think planning makes the whole difference. And these are the patients who are least expecting, because I've always heard from doctors saying there's a scar, there's nothing much, and they have the highest gratitude if you really help them out. And we should also know when to reject. It's not all cases that you can look at a refractive, as Shreyas told. A lot of these intense scars do require a PTK, then only refractive. So always know when you reject for an excimer. And I think this is one area where there's no protocol. There can never be an algorithm, because every scar that walks into you is a different case. And I think the planning has to be totally different. So I thought this case was good just to see the minuscule level of planning that goes a long way in giving good refractive results to our sky corneas. Thank you so much.